forestall the need to do a radical procedure without compromising our ability to cure. So we're actually moving in the other direction of treating fewer people with these very aggressive treatments that, yes, can cure you, but have tremendous morbidity. It's a good question.
Yeah, I'm taking a combination of medicines for probably over 10 years under the supervision of a urologist. And I notice at night, some nights I'm up more than others to urinate. So my question is there a positional effect in how one sleeps in terms of how often one has to urinate?
So the one thing I counsel most men is that nocturia, which is nighttime urination, does not automatically get better with prostate treatment. If you could snap your fingers, make the prostate magically disappear, and the amount of times you go to urinate at night might not change at all. Nocturia has so many different factors that go into it. It might have to do with your heart, your kidneys, leg edema. It's an issue that gets worse as someone gets older. So actually, technically speaking, or medically speaking, up to at least on average 2.5 times a night to urinate is completely normal. So it also might have to do with certain medicine. So if you're asking about positions, the answer is yes. When you're lying down, your legs are elevated. When your legs are elevated, there's more fluid return from the lower part of your body to your heart and your kidneys. So you make more urine at night than you do during the day. So men with enlarged prostates, if you already have a daytime frequency issue, that gets worse with night because you have more fluid to deal with. So if you treat those men, then yes, the nighttime urination issue could improve as a result of that. But it's not completely going to resolve. So nighttime urination has so many different factors that go into it. And there's actually no real approved medicine, no approved safe medicine, I should say, for that issue.
You haven't talked about any exercises, like the Kegel exercise. Is that any help?
Kegel exercises, we sometimes do have men do Kegel exercises. Kegel exercise is something that tends to be more effective for stress urinary incontinence. There is a reflex called the storage reflex, and by doing the Kegel exercise, for people who don't know, Kegel exercise is an exercise where you're contracting this sphincter here that is right beyond the apex of the prostate. And when you contract that muscle, not only does it hold the urine in, but it also makes the bladder relax. And so for people that have urge incontinence and stress incontinence, sometimes doing those Kegels can help, in addition, in conjunction, say, with decreased spicy food, decreased caffeine, decreased alcohol, some of the things Dr. Boschko mentioned can help in sort of the non-pharmacological management of the condition. It tends to help women a lot more than men. Women tend to get problems with leaking and overactive bladder too. But yes, we sometimes use Kegels for men. After prostate cancer surgery, it does help, resuming continence, and there's a muscle that you can build up. You got to do about 200 a day to kind of really make it work, which is a lot, but it's something we do.
Yes.
How do you assess the quality of your bladder?
Okay, so the quality of the bladder, that is probably the least straightforward question that there is. So Dr. Blair had mentioned there are a number of different studies that we do. Let's try to get it here. We have specialized testing. So you could have a normal urinary flow and have a complete obstruction, because if your prostate is blocking up the urinary pathway, your bladder can strain a lot to get the urine to come out. So the end result is the urinary stream still looks good. Okay? So you can't go by the strength of the stream alone. There are certain pressure tests. The one that we use the most is something called a Eurocuff, because it gives us the most amount of information with the least invasive part of it. There's nothing inserted inside of you at that point. It's a little mini blood pressure cuff that gets wrapped around your penis, and as you urinate, it squeezes. And what it does is it's a computer nomogram in the software. So the whole test tells us not only the flow and the volume that you urinate, and use an ultrasound to see what's left, but that cuff test tells us what your bladder is doing when you urinate. So if the bladder is straining, you can follow that over the months or years. Is it straining more and more and more as the time goes on? Then you know that long term that's going to affect the bladder in a negative way. Okay? If you see the bladder straining 1 year, and then the following year it's not really straining and you're holding a lot of urine back, that's actually worse. Because the reason why it's not straining, it's inappropriately not straining. That means the bladder is starting to weaken. So that's the Eurocuff is a big test that we use. It gives us a really lot of information that we can use for somebody's bladder health.
Then how do you know how close you are to Jesse James?
So that's, again, so that depends on cystoscopy, ultrasound, urocup. It's not just one test or another. You have to look at it as a global picture.
There's a gold standard test that we didn't really kind of get into called urodynamics, which is the most invasive functional study of the lower urinary tract, where we're really accurately measuring that pressure, even more accurately than the cuff, by placing a catheter both in the bladder and the rectum. And we're taking measurements of the electrical activity of your sphincter. As we fill you up with fluid, we're taking measurements, and then as you empty. So we have a lot of ways to get data. Like Dr. Boschko was saying, we want to try to answer the questions that we need to answer in the least invasive fashion. But getting information about your bladder, as you're alluding to, is very important in order to provide appropriate treatment. We don't have any more general questions from the group. It looks like we got one more.
Yes, apart from the fact that a patient on medication may not like to have to take the medication, what would lead you to recommend to that patient that he undergo the urolift procedure? Is it covered by Medicare, and is it generally effective for how long?
So that's kind of like a general question. It is covered by Medicare. Okay, that's an easy one to answer as far as that goes. In terms of switching you off of medicine, again, it has to do with two separate issues. Have your symptoms changed? Your quality of your life, your subjective way that you are urinating, do you feel like you need something else? That's one. And the other is, objectively, all these tests that we do to follow you over the years, do we see that your bladder is getting negatively impacted by the continued obstruction of your prostate? And if we see that the bladder is starting to weaken and getting worse and worse, well, we know that trajectory, because again, nothing gets, you're not a bottle of wine, it's not gonna get better with age. So it's just gonna get worse and worse and worse. So if we see that the bladder is starting to change, that's when we start, from a physician standpoint, that's when we start bringing that up.
Twisting your arm to do something. Yes.
How frequent is urination at what point would you consider it a problem?
So, I mean, there's kind of quick rules of thumb. Dr. Boschko mentioned 2.5 times a night. It's kind of normal.
No, I'm not talking about night.
Yeah, during the day, if you're urinating more than about every 2 hours, drinking a normal amount of water, that's when we start to wonder, is there an issue with obstruction and BPH there that we need to investigate?
And what frequency would you be leaning towards one of the procedures?
So the frequency is just one piece of data. We can't just take one piece of data and say, that guy needs a resume. Here's what his frequency is, or that guy needs a TURP or a laser TURP. Frequency is one piece of data. We have to look at the whole picture. Every picture can be a little different. And I can't give you sort of a hard and fast rule just based upon.
I'll give you an example of what he just said. So you could have frequency of urination, and it might be from two completely separate issues. You might empty out your bladder 100%. You've got 6 ounces in your bladder, you go to urinate, it all empties out. But the bladder is straining a lot to get the urine to come out. You get an overactive bladder, and your bladder doesn't want to stretch so much because it's lost elasticity, so you go to the bathroom more frequently just because your bladder doesn't want to hold it. So you go frequently as a result of that. Vice versa, you could have someone who is been treated for an enlarged prostate or not treated, but they're not emptying out their bladder at all. They start off with 6 ounces and they urinate 2 ounces. And they leave 4 ounces behind. Well, guess what? Your bladder's gonna fill up that much more quickly. Then you go to the bathroom frequently because you fill up quicker. Two completely separate clinical scenarios, but the outcome of the frequency is exactly the same. And that's why it's not just one thing or another. You have to look at everything.
Yes.
Now, if one is diagnosed with prostate cancer, do they go see an oncologist or a urologist?
Well, first of all, the diagnosis is almost certainly made by a urologist. And so they're gonna probably be seeing a urologist because the urologist is the one who does prostate biopsies, and that's how the diagnosis is usually made. So you're usually gonna start off with the urologist. When the disease is organ confined, you're gonna have to have a conversation about the different treatment options. And just like with prostate enlargement, there's an armamentarium with pros and cons of each treatment option. Active surveillance versus radical surgery versus external beam radiation, whether it's intensity modulated radiation or cyberknife versus high intensity focused ultrasound, HIFU versus cryotherapy. These are all the kind of options where we treat you with curative intent when the cancer is organ confined. It's when the cancer is no longer confined to the prostate. That's when a medical oncologist may have a big role, because that's when we can't cure the cancer. We can only slow it down. And that's when you're gonna be on what we call systemic therapy, whether it's hormone ablation or docetaxel or some other drug that treats the entire system, including cancer that may have metastasized to bones or lymph nodes. So the main role for a medical oncologist is that systemic therapy for cancer that we can no longer cure. Does that answer your question?
Yeah.
Yes, sir.
Gleason test, waste of time or useful?
Excuse me?
The Gleason test, is that a waste of time or is that useful?
So there's no such thing as a Gleason test. What it is if someone has a biopsy for a variety of different ways you wanna assess a person's risk factor of having cancer, if the biopsy comes back as showing cancer, the Gleason score is how you categorize somebody in certain risk categories. So there's low risk cancer, there's intermediate risk cancer, and high risk cancer. And the Gleason score is the first step in categorizing that. It's not a sole test. What Dr. Blair was talking about, there are certain genomic tests, like the Polaris test, that even within Gleason 6, let's say low-grade cancer, there are certain low-grade cancers that will act low-grade, but there are also certain ones that on the Gleason score will seem low-grade, but they will act a little bit more aggressively. And that's what the gene-based test tells us. But it starts off with the Gleason.
So we thank you guys for coming. We enjoy talking about this. If anyone has any personal questions, we're happy to stay and address those on a one-on-one basis. So thank you again. Have a nice night.
Thank you.